So now I'm talking about the massive tear, the tendon transfer, and also the SCR. Okay. So when we're dealing with the massive tear, before you jump to do the reverse, okay. So another option is to fill the gap. You can fill the gap with the local tendon, like tendon transfer, or you fill the gap with tendon from the distal part, like from the hip, right? So actually, it's the same things. So the tendon transfer is in the past, it's very common if you have the gap in the back. Suprainfraspinatus, you transfer the LD. Okay, LD is very popular. But nowadays, the lower trapezius is become very popular, right? Using the graft. You can use from allograft or from the knee, hamstring, or pec longus. So for the anterior part, there you can use the pec major or pec minor and LD transfer. Okay, so this is the Bassem El Hassan, right? He described this the lower trapezius, right? So first, for me, I start with mid-shaft position. We identify the lesion. I use the tendon from the knee. Okay, I use the superficial quadriceps tendon, and then we get in the joint, we cleaning. So for me, I prefer to do some augmentation. Like this patient have very big supraspinatus and also the infraspinatus tear, right? So we do partial repair of the supraspinatus. Okay, and then we this is a supraspinatus. We repair it first, and then we transfer the lower trapezius from the back. You make a window, make a nice screening. Yeah, here. So that is the graph. I use the mechanical augmentation because I can use this patch to augment your repair, right? To make a better mechanical and biologic augmentation, right? Okay. Then you repair this to your supraspinatus. Okay, like this. Okay, make a suture bridge technique. Okay, so after that you move to your this is the repair. Okay, so you can cover, and then the posterior part you can make a side to side to your lower trapezius, and when you tension, I do the maximum external rotation, right, like this. Okay, so after surgery you immobilize the patient in full external rotation, right? So this is the quadriceps, right? I use quadriceps graft for the lower trapezius transfer. The function is very good, yeah, and the outcome is much better. Full motion, okay, no pseudo paralysis and good strength of supra and also the. And for the LD, I think nowadays the LD transfer in the past is very common. I still use LD transfer, LDTM for my reverse. Okay, but for the rotator cuff, I do it less. I do less LDTM transfer. I do lower trapezius and also I do SCR, right? Because if you have supra and infra, if you have big SCR, you can cover supra and infraspinatus at the same time. Yeah. So for me, I do less. And this is a pec major transfer. You can transfer pec major, put it under your conjoint tendons like that. This is a pec major transfer. It's easier, right? But some surgeons prefer the LD transfer. Yeah. For the patient have only defect on the top. So the tendon transfer, mostly we want to cover the front or the back. Like you have big gap in the front, you use pec major. In the back, you use lower trapezius, LD. But the defect on the top, tendon transfer is difficult to cover the top. So most of the patient, I do the superior capsular reconstruction for my superior defect, right? If the patient have not the big tear, you can use biceps, SCR, yeah, for the augmentation. Those patients, if you have enough tissue, you can make side to side and bicep on the top. But if the defect is too big, I think the supracapsular reconstruction is more reliable. Okay, like this. So that proposed by Dr. Mihata, but the Hamada should be less than 3. This patient have the massive irreparable calf tear, 53 years old, right? And also the patient have black side, right? So subscap is good, yeah. So this patient, this is an MRI, okay? And we harvest the IT band, but you know, the incision is very big. So actually, that's why many surgeons, like the high volume surgeon, don't like to do that. Like in Australia, right? You have no one like that. Right? So someone say this is very popular in Asia, but not in Europe, not in Australia, right? Because there you make a lot of invest, right? And then this is our in-house technique. We make triple lumens technique because you have many sutures. You have 24 sutures that you need to manage, right? So I make like this triple lumen technique so that it will be easier for you to manage your suture. Okay. So this is the way we do the supracapsular reconstruction. I put the 10 cc syringe and make triple lumen for my suture management, right? So that is a way to do that. Yeah. So you pass the graft into the joint, okay, and you tie the supraspinatus and the rest of the tendon over your graft. This is your graft, yeah. So you make knot tying, and this is the MRI before and after the surgery, right? You can have very nice healing, yeah. And you see the function of the patient, the strength is better. This is about 5 months, okay. And also the external rotation, yeah, it's better because I make very big graft over the infraspinatus, and also I repair my infra to my graft, yeah. So it's not that perfect, but the patient has no lag side, yeah. So for me, if the patient have supra-infra, I prefer to make big SCR, yeah. So this is a 63 years old, yeah, the supra-infra, yeah. Very big tear, same things, right? We make SCR, we make 12 sutures. Yeah, put it in. And the rest of the calf always on the top again. I repair the stump of the rotator cuff to my graft. This is autograft, right? You can see it is on the top. Yeah. And that's a healing of the calf, right? You see it's very thick. Yeah. We need 8 millimeters of thickness. The surgery. Yeah. And that's a healing. Yeah. So you see the infra also good. Yeah. This is a function 2 years after that. Patient good. External rotation also, you see, it's better comparing to before the surgery. Yeah. And that is a hip, right? I'm not happy to see this wound. It's so big. And the patient suffering from this pain for a few months. Yeah. So, but anyway, final follow-up, there's no problem with the hip. Sometimes they have some celoma because you have very big incision, there's some pocket and fluid, right? So I use some dermal graft, but I feel like my outcome is not so good. Like this patient, I use dermal patch. Okay, you see that the graft healed, but it's torn finally. Yeah. So I stopped using the synthetic one, right? I use allograft also. Yeah, this is allograft. Yeah. Yeah, the allograft. Sometimes good, sometimes not. This patient have, I think the healing take longer time comparing to the autograft, right? So nowadays I changed my technique. We published the technique using the superficial quadriceps graft. I use that for my ligament knee reconstruction. Yeah. So you can harvest it from the knee joint, make a small incision. Actually, this is proposed by the Indian doctor, Dr. Rajiv Brahman from Kolkata. You know him, right? So he's the one who proposed this. I think this graft is very good. It's wide. See that? When we take it out, the width is about 4 centimeters. That's perfect for the supracapsular reconstruction. You spread it, okay? And then you can flip it 4 times like this patient. Very big tear. So we harvest the graft from the knee first, like that. Okay, you get the graft like this, and then you flip it. And also, I take the biceps because I did not use bicep. I cut the bicep, make it long, and put my bicep inside. It's like sandwich. Yeah, put the sand inside, and then you can have bigger, thicker graft, right? And then we get in to do the supracapsular reconstruction. I also release collateral ligament like Dr. Juhani recommend. That's good to prevent the post-op stiffness. Okay, so that is our graft, right? So we get in, and then we make side to side first, okay, and then make suture bridge, same like you do rotator cuff repair, okay. So, and check again the stability of the graft. You see, this is the knee, okay. Next day after surgery, okay, patient have good extension. Even she is 60 years old, yeah, the outcome is good. Patient never complain about the knee function. This is a month after that. You see the incision of the knee, and the knee function is quite good, yeah. So for me nowadays, I use this as a primary gap choice because you know the hip tendon is, you need a very big incision, right? And patient always say no if you harvest the hip tendon. Yeah, I say knee ligament, knee tendon. They say okay because patient feel familiar with the knee ligament reconstruction. Yeah. So the outcome 3 months, the patient getting much better after surgery, right? And this is a healing after the surgery. So I think in summary, I think the tendon transfer and supracapsular reconstruction, it's in my hand, in Asian way, we still have very good outcome. Yeah. But I know in some countries, in Western, in Australia, they are worried about the donor mobility, right? Okay. So thank you so much. Any questions?